So I will sort of basically start off in terms of perhaps giving a bit of a background to the speech. So how the forum came about was I'm kind of interested in the history of health economics and its influence in Australia and other countries. And one of the joys these days in terms of trying to understand influence and I suppose history of thought and the proliferation of ideas is you can now search large public databases, including Hansard, and search for individual words, which of course we couldn't have done without computers. And so I went online to Hansard a few years ago and typed in the word health economics, trying to find the first use of the term, and came across this speech, and I thought maybe there was a passing reference, but no, the entire speech, and interestingly was written by Gough Whitlam, which obviously everyone in Australia would know as a famous former Prime Minister. And the fact that the speech, as I said, really provided a sort of a coherent narrative about what needed to be done. So I thought it was really a real opportunity, as the 50th anniversary approached, to start to use it as a sort of lens to look at today. And obviously, if we can learn lessons from history, hopefully we won't repeat the sort of problems of the past. So it clearly has relevance today, I think, both in his analysis of the shortcomings and problems we face, and I will try and point out how the parallels to what he was talking about and the problems we face today, as well as, interestingly, a real package of proposals of reform. And he, again, it's worth assessing those and saying, are they still relevant today? Could we implement them? What impact and what are perhaps the impediments? And I suppose finally, one would think, well, over such a span of history of 50 years, well, really we should be thinking about designing and modernising our healthcare system for the next 50 years. So if someone meets in 50 years' time, they can assess our ideas. So I suppose the forum obviously has an historical perspective. It's clearly concerned with the present, but we really should be concerned with the future as well. So I think all three phases will be addressed by speakers in this today's forum. I think importantly, and in terms of trying to get an historical perspective, it was written at a time in 1967 when there was no universal healthcare in Australia for medical and hospital services. But the Commonwealth did have a universal health program, which was the PBS, that had started in 1948, and this was the main program that the Commonwealth government was managing. So the speech has a focus on pharmaceuticals. At the end, there's clearly a view that Whitlam's starting to think about design or adding to a universal health scheme, which became Medicare. And interestingly, it was the same year he met John Deeble and Richard Scotton, both who were the architects of Medicare, and we presume it has some of their ideas in this speech, and other people that have been suggested or may have contributed are people like Peter Walensky, and so there were a sort of a group of young academics who had interaction with politicians in perhaps potentially shaping future health policies in Australia. So perhaps to give a historical sweep, one can easily obtain from public data the total government expenditure on pharmaceuticals going back to the creation of the Pharmaceutical Benefit Scheme. And here I've adjusted this for inflation to $2,016 and just provided the period perhaps immediately prior to and sort of after the Whitlam government. And as you can see, pharmaceutical costs, or the expenditure of the Commonwealth, had been rising. And this clearly became a key sort of focus of Whitlam's attention. And as you would see, over the term of his government, the costs did rise a little, actually not that dramatically, and possibly by the end, by 1976, they were actually back down in real terms to where they were in 1972. And as you can see, they were relatively flat for the following decade in real terms. But people should remember it was a period of relatively high inflation. Interestingly, from 1990, as you can see, pharmaceutical expenditure in Australia has dramatically risen. I often put this on this same slide, which it actually coincides with exactly with the period when the Economists got involved in assessing pharmaceuticals in Australia. And I'm not too sure whether we're responsible, but perhaps there are some other explanations, and one might say that it was a time when the volume of pharmaceuticals increased, particularly blockbuster drugs, which I think have had a dramatic effect in or significant effect in reducing rates of cardiovascular disease and improving the outcomes of people with diabetes. But also perhaps another thing which perhaps people didn't realise at the time, if you were old enough to remember the early 1990s, it was a period of a deep recession, that really one of the outcomes of that was it broke the back of high inflation. But I think, although obviously I think having low inflation is generally good, for governments I think it really does remove a very significant lever to control expenditure, because most of pharmaceuticals and many government payments in the healthcare space are in nominal terms. So if you've got a high rate of inflation, you can just sit on your hands and basically inflation will do the work for you of reducing expenditure over time. What happened from the 1990s, once inflation dropped, is you've actually got to be quite proactive at trying to reduce the price, or in real terms, of benefits. And so that's something I think governments have had to struggle to come to terms with. As I said, and perhaps this is, hopefully everyone has read this paragraph, I can't think of a more succinct paragraph describing the problems of and issues we face in the way government operates in Australia in terms of being fairly, as Gough Whitlam terms it, laissez-faire. I will stress, by the way, we have kept the text to the absolute original. There are a few errors in the text, but they are as they appear in Hansard. Government plays largely a passive role. He talks about ministers basically being content to authorise checks unless there's kind of great sort of abuses, as it were, and then says medical research or healthcare or research in Australia is fairly narrowly focused around sort of medical issues, all of which I think has some resonance today. Interestingly, his prescription in the early part of his speech is he says, well, we basically need more economists. And he got a question and asked a question of the minister saying how many economists were there in the then Department of Health, and the minister replied around 5, although there's some other people in other parts of the department. And he basically said that was inadequate. Canada had, I think, 50, and that we needed to expand the number of economists and economic analysis and economic research. I must acknowledge, I mean, since that time, clearly aspects of that have been addressed. I'm sure there are more than 5 economists working in the Department of Health now. Many are working around economic evaluation. I would say, though, there is no chief economist, and I'll perhaps make mention of that later on in the day. Better data, so was his sort of next theme. Again, he was very scathing. The then Minister of Health, again, they'd asked very detailed questions, and I believe that these questions were actually either inspired or written by most probably academics. And I've heard from more than one academic, this is a time when there were shadow ministers, had no ministerial staff or advisors, so they actually had to reach out to academics to try and ask questions or get appropriate issues for them to ask questions in Parliament. So basically the minister couldn't answer what was Australia's total expenditure. Well, I can very pleased to report we can answer that question, and today the AHW released its report on overall expenditure, and we're now at 10.3% of GDP. We've just gone over 10%, mainly not because of a rapid necessary rise in healthcare costs, but obviously when healthcare costs are generally rising faster than inflation, that has happened, and it will, the rise as a proportion of GDP will continue into the future. But I do think we grossly underutilise many of our resources in terms of data linkage and using individual data from both the PBS and MBS data. And also we don't link those data with other sources of data, such as tax records, to understand, for example, the progressivity of the system. So there's a real urgent need, and again, one of the themes of this will be to have a look at what's happening in New Zealand, where they've basically linked up most of these data sets well before us. Then I think Whitlam has a very interesting, most of the speech is devoted to how to tackle what are the waste in the system and how to potentially tackle that. And he argues that based on evidence, and again written by academics at the Melbourne Institute, that we had very high rates of expenditure then in terms of our for pharmaceuticals. And he argued that Australian doctors tend to prefer the most expensive drugs for their patients, and there were very high margins on some pharmaceuticals. Now, this is still true today, and I'll perhaps show more evidence of that this afternoon. But in terms of high prices, perhaps the clearest graph, and this is a few years old, and I think that this problem has largely been corrected. We used to pay extremely high prices for many generic pharmaceuticals compared with countries like England. I would stress now that policies such as price disclosure have been able to bring that under control, and these days it's not so much of a problem. But then perhaps where the next problem has shifted, although now the price we pay to manufacturers is actually low, interestingly, the margins we pay for pharmacists for some of these drugs appear quite high, and these are two commonly used drugs. Most of you would have gone to a pharmacist for amoxil. If you have diabetes, you'd go to the pharmacist for metformin. And as you can see, in the case of amoxil, the pharmacist is paying less than $1, and they potentially are charging under these are the scheduled fees for general patients, around $18.80 for amoxil. It's a little bit lower for concessional patients, and $19 for metformin. So these are really sizable margins, and obviously Whitlam has these questions in the speech saying these are very large margins. Can we find ways to make it more efficient? And just as a bit of a teaser, what I've done is put the price from a large, as it were, chain pharmacy from the United States for these drugs, and what you've got to say prima facie is that a person would get drugs much cheaper, those drugs much cheaper in the United States, so it's worth asking the question, what is the additional benefit for those higher prices? Another issue that Whitlam raises, which is still around today, are fixed co-payments, as you know, particularly, say, with concessional. If you have diabetes, you now have a choice between around 10 or more drugs. As you can see, if you're on a concessional patient, you pay $6.30 for all of them. The cost to the Commonwealth differs between basically a few dollars to almost over $100. And again, the issue about whether it really is sensible to have just a fixed co-payment is something Whitlam asked, and I think we should ask here again today. And the point he made was the main competition. Once you've got a fixed co-payment, there's no incentive for the patient or doctor to choose a lower price medication, but the main competition in the system is advertising between companies for different brands of pharmaceuticals. What can we do? As I said, he had a real sort of menu of different options, which are slightly breathtaking by today's standards and with the way current politicians talk about what could be done. So the first thing he thought we should introduce a system of competitive tendering, and as most of you would know, that does happen in Australia, but only on a state level. I'm really very unaware the Commonwealth tenders for any services on the PBS or MBS currently. And again, that's a question we should ask. And if we look to New Zealand, they've clearly gone down that road, and we could perhaps learn some lessons of the potential benefits and any sort of dangers in that. But again, the question Whitlam asks, we can still ask again today. I think a really fascinating aspect of the speech was Whitlam's views on pharmacy. They were, I think one would say, he would be in a very small minority in the current Australian Parliament. He argues that basically the restrictions that prevent supermarkets from owning pharmacies should be removed, and more generally, any sort of restrictive practices should be removed to introduce more competition, and that this competition would benefit consumers and taxpayers who pay much of the drug bill. Now, I think since that time, so the ownership rules were that only a pharmacist can own a pharmacy. Since that time, we've actually gone to have even more restrictions. There's restrictions called the location rules. And it's one of those things, I think, for politicians, when they do mention introducing more competition and addressing these rules, it tends to be in their farewell speeches. They don't generally make them in Parliament, except David Leonhelm. And I think the interesting idea that Gough Whitlam and David Leonhelm share something in common is kind of an interesting thing. But I can't find, if you know of any other Australian politician that takes the view that supermarkets should be able to own pharmacies, or we should have chain pharmacies in Australia, let me know. Interesting, just to explain the location rules just in a very practical way, and this is really the only sort of detailed location issue I know about in terms of, because all of the decisions made by the tribunal that decides these matters are kept secret, but I think Peter Martin reported this in The Age. But so if any of you live near Hackett, you can't go to the Hackett pharmacy. There was one when the shops were created. It closed down in the 1990s. Now location rules, and what location rules are, is you can't open a new pharmacy if we're within 1.5 kilometres of an existing pharmacy. In this case, in the neighbouring suburb of Watson, there is a pharmacy 1.35 kilometres away. It's 155 metres too close. But what the person argued, who was wanting to open the pharmacy, is we'll keep the medicines just that bits outside the pharmacy, and we'll kind of carry them back and forward. And I personally find this quite crazy, and the idea that ministers and ministerial committees and health departments are saying where you should locate shops, quite bizarre, but maybe I don't work for government. But as I said, the product of these two rules basically has created effectively no change in the number of pharmacies. This is data that wasn't published, but I got from the Department of Health, and it's the number of pharmacies, again, going back to 1950. And a really interesting fact that is that the number of pharmacies in Australia in 1965 is greater than the number of pharmacies today. And as you can see, the pharmacy population ratios are on the rise. So we've got to think about, is this an optimal sort of strategy? At the same time, the number of medical practitioners, which Whitlam also mentions in his speech, has risen tenfold. So just to finally conclude the program for the day, we have basically broken into three sections. The first section is going to be, I suppose, chaired by Professor Bob Gregory from the ANU. We're going to have Michael Woolridge and Andrew Lee, I suppose, provide observations as a former health minister and as a current shadow minister, although Andrew will mainly be speaking about randomised policy trials. And then we're very fortunate to have a chief economist, Bronwyn Coxon from New Zealand, who will be talking about how economic thinking sort of influences health policy in New Zealand. We'll have a series of speakers in the morning then, focusing on sort of economic aspects and potential scope for reform. In the afternoon, I think we'll try and focus a little bit more on data and trying to sort of integrate data into economic decision making. And the afternoon, which I'm very much looking forward to, we'll be looking at the third part of Whitlam's speech, which is promoting efficiency, and we'll have Stephen King from the Productivity Commission and Terry Barnes both addressing that subject. So without further ado, I'll hand it over to Bob. And perhaps one would say Bob needs sort of no introduction. He's been an economist active in public policy for many decades, and was also at the first Australian Health Economists meeting, although when I let him know this fact a few years ago, he said he just couldn't remember going. But anyway, he's on the record as being there. So thank you, Bob.